everyone. My name is Olivia Jacquemart. I am a QA and trainer with ViaQuest Psychiatric and Behavioral Solutions. And today we are going to be going over working with nonverbal clients. First, we actually have to look at our objective for today's training. So what are we even trying to learn? We want to learn who may be nonverbal and why, figure out communication styles of nonverbal clients. We will learn how to implement interventions with nonverbal clients and how to properly document working with nonverbal clients. But what does it mean to be nonverbal or non-speaking? So nonverbal clients can be anyone, whether it is a choice that the individual is making or not. So nonverbal clients are clients who struggle to communicate through verbal or vocal speech. And this can include those with limited speech or a client who chooses not to verbally interact. There are a few reasons and diagnoses why someone might be nonverbal. So it could be due to those emotional or mental reasons. There could be any physical reasons, as well as cognitive or intellectual or developmental disability reasons why. So this list here includes some of the most common reasons someone presents as nonverbal. However, this is not all encompassing, and there could be another reason as well. Just getting to know your client is key. So some of the main ones that we're going to be going through include selective mutism, social anxiety. There could be a trauma response or disassociation, stroke, aphasia, or brain injury, as well as nonverbal autism and nonverbal learning disorder. So first, looking at the mental and trauma diagnoses or reasons why someone might be presenting as nonverbal. So that's selective mutism. So this is a mental health condition where you can't talk in certain situations due to fear or anxiety. So causes can include childhood environment, past trauma, genetics, social triggers, and speech or language difficulties. So our clients with selective mutism may struggle immensely with advocating for themselves. And then that's social anxiety. So chronic or persistent anxiety can negatively impact the cognitive part of speech production, as well as the physical process of speaking. Feeling pressure to interact in ways they don't feel ready for, being criticized or humiliated, or having other fears and worries can make social anxiety worse. So symptoms of social anxiety may include a fear of being criticized, avoiding eye contact, or having low self-esteem, all things which can lead to someone participating in non-speaking behaviors. And then there's our trauma response. So trauma blocks the vocal process as it affects the involuntary nervous system, body, brain, and memory function, all of which affect the way we speak and communicate with others. If a client's flight, fight, or freeze response is activated, people with a history of trauma can experience a form of dissociation that renders them unable to speak, even if they want to. So most mental health professionals do believe that the underlying cause of dissociative disorders is chronic trauma in childhood. Disassociation is a way that the mind copes with too much stress. So people who disassociate may feel disconnected from themselves and the world around them. And then those physical reasons. So first could be a stroke. So stroke, this could be that non-speaking occurs because one or more regions of the brain that control language and speech have been either injured or damaged. So someone who has had a stroke may not be able to translate their thoughts into coherent speech, and they may not understand what's being said when other people are speaking. Then there's aphasia and apraxia. So aphasia is the loss of ability to understand or express speech caused by the damage to the brain, or apraxia, a motor speech disorder that makes it hard to speak. So both are language disorders that affects a person's ability to communicate, and causes of aphasia or apraxia include that stroke, head injury, or from a growing brain tumor or underlying disease. And then brain injury. So the brain is very delicate and each structure within it performs very specific functions. Included is our ability to understand and perform those language skills. So when our brains are damaged, we can suffer from several different speech impediments, including stutters, slurred speech, vocab problems, and understanding language, making verbal communication difficult. So just going through a few of these really quickly, the main difference between aphasia and apraxia So, apraxia of speech affects the coordination of the muscle movements, so the actual physical movements required for producing that speech, whereas aphasia affects the language retrieval, recognition, and comprehension. And then the brain injury there. So, when a brain injury occurs, the ability to convert our thoughts into language by manipulating our vocal cords and tongue physically can be affected. So, while some speech impediments are a result of damage to the tongue's vocal cords or even how we're taught language, much of our ability to speak is a result of our brain functions. And then within the IDD or intellectual and developmental disability population. So, first is that nonverbal autism. So, nonverbal or non speaking autism is a subset of autism spectrum disorder where the person does not learn how to speak. So, one study has shown that 64% of autistic children who are nonverbal at age 5 are still nonverbal 10 years later. And around 40% of people diagnosed with ASD have nonverbal autism. And then there is nonverbal learning disorder. So, nonverbal learning disorder is a neurodevelopmental disorder characterized by core deficits in visual spatial processing and a significant discrepancy between verbal and nonverbal intelligence. So, a person can be diagnosed with both autism in addition to nonverbal learning disorder, but a person diagnosed with ASD does not necessarily have nonverbal learning disorder and vice versa. They are not the same. So, nonverbal learning disorder symptoms often include things like trouble with skills understanding concepts, trouble finding patterns, and organizing information, making communication difficult. And it is important to look at all of our clients' SNAP. So, the ViaQuest SNAP being strengths, needs, abilities, and preferences. So, clients with an IDD diagnosis have an increased likelihood to struggle with verbal communication. Understanding their ability to non-verbally communicate can help us understand our clients easier. And just some of the prevalence of mental illness and those with an intellectual or developmental disability. So, as of 2021, 28% of adults in Ohio do have some type of disability. And almost half of these individuals will have a co occurring diagnosis of depression. So then Ohio statistics are actually higher than the national statistics. So according to the CDC, 27% of adults in the US have some type of disability, whereas that's 28% in Ohio. So it is likely to be working with clients who may struggle with verbal communication. In this presentation, we will only be referring to those clients who have a moderate or severe form of IDD, as they are more likely to be nonverbal. Those with a mild IDD diagnosis are typically going to be verbal or struggle less with that verbal communication. So then first looking at those individuals with a moderate IDD diagnosis, this does tend to be about 10 to 12% of people who have been diagnosed with IDD. So there are going to be noticeable delays, particularly in that speech. They may have an unusual physiology. So physiology is the way in which a living organism or body part functions. The typical skills repertoire includes simple skills, simple communication skills, simple health and safety skills, some tasks of daily living or self care, and independence in the community in familiar places. And then those with severe IDD, which is about 3 to 4% of people with an IDD diagnosis. So there are going to be significant delays in some areas. This includes that they may walk late, have limited expressive communication skills. The typical skills repertoire includes daily routines and repetitive activities, fewer complex tasks of daily living and self care, and can have social skills with support and supervision. So, those clients with severe IDD may not be able to express grievances, such as mental frustrations or even physical issues and pain, due to those limited expressive communication skills. This in itself can lead to aggressive outbursts from not being able to communicate. By implementing communication methods that can benefit those clients with a severe IDD, such as social stories or pictorials, a communication board with pictures, or even digital communication methods, we can improve their overall health and wellness. So we will talk about these methods a little later into the PowerPoint. And then just some more of these communication disorders here. So first is the language disorder. So the language disorder is where a person has persistent difficulties in learning and using various forms of language. It could be that they have a low word knowledge. So if our clients have a language disorder, they may benefit from utilizing pictures or drawings as best ways to listen to our clients. And then that speech sound disorder. So they could have trouble saying sounds clearly, and it is hard to understand what they say. However, they can easily utilize a communication board of any fashion. And then there's that childhood onset fluency disorder, otherwise known as stuttering. So sounds and syllables are being repeated. There are broken words as well as whole word repetitions and word substitutions. So if someone prefers to not verbalize some words due to stuttering, they may be able to write them down. They may want to verbally communicate more so than others. And then here we have SOTA. So SOTA being an acronym for substitutions, omissions, distortions, and additions. So substitutions, so you're replacing one sound with another. So it could be wed instead of red, soap instead of soap, or dut for duck. There's omissions, which is otherwise known as deletions. So you're omitting a sound in a word. And this error often affects the intelligibility the most. So this does make speech more difficult for the listener to understand. So some examples of this one could be pe the piano or Nate for green snake, pe the piano for play the piano. Those are examples. And then the distortion. So producing a sound in an unfamiliar manner, literally distorting the word. So it could be that things are lips or sound slushy, anything like that. And then the additions. So you're inserting an extra sound within a word. So it could be black horse, but lack horsa, or dogga for dog. And next up, we do have a quick video on social communication disorders.
You know what's smart? Treating yourself without cheating your goals. Eat smart with Factor.
What is social communication disorder? Social communication disorder, or SCD, is a developmental condition that impacts a person's ability to participate in social settings, develop relationships, and perform well at school or work. It was previously considered part of autism spectrum disorder, or ASD, but its symptoms now merit a standalone diagnosis. People with SCD struggle, specifically, to shift their communications to fit different circumstances. The following may seem out of sync or inappropriate in some situations: tone of voice, pitch, volume. People with SCD may also fail to use gestures like waving or pointing, talk about emotions, take turns when talking, stay on topic, ask and respond to relevant questions, make and keep friends. In children, early warning signs include delay in reaching language milestones, low interest in social interactions. SCD can occur alone or alongside another condition, like ASD or a learning disability. Screening involves interviews, observations, and questionnaires completed by parents, teachers, or significant others. Learn more here.
So that was just a little bit extra on social communication disorder, but we are now going to start getting into autism spectrum disorder. So autism spectrum disorder is characterized by persistent deficits in social communication and social interaction across multiple contexts. So there are restrictive, repetitive patterns of behavior, interests, or activity. Symptoms must be present in the early developmental period, cause clinically significant impairment in social, occupational, or other important areas of current functioning, and are not better explained by intellectual disability or global developmental delay. So understanding clients on the spectrum can help us better communicate and provide better support. So we are helping them help themselves. And people who have an autism spectrum disorder often will have difficulties with social relationships, transitions, that communication in language, perseveration on interest in activities, dependence on routine, abnormal responses to sensory stimulation, as well as an increase of behavior problems. So we are just trying to understand our clients and where they land on the spectrum to provide better support and communication. However, those with ASD often will have strengths that can lead to good communication skills in other areas than verbal. So some of those common strengths include nonverbal reasoning skills, good reading skills, perceptual motor skills, and drawing skills, computer interests and skills, exceptional memory, visual spatial abilities, and music skills. And although some areas of development in a person who has autism are delayed, people who have an autism spectrum disorder often exhibit skills in other areas. These intellectual strengths may overshadow the developmental problems that are experienced. And next up, we're going to look at another video from this speaker, Tyler McNamer. He was diagnosed with autism at the age of 2, and Tyler was nonverbal until 6 years old and didn't speak in full sentences until 12.
There's a lot of ways of trying to get the message out there, and without the use of verbal communication. My way was simply just writing. That's my personal thing is to write words, and that helps me communicate. I feel like I can write. I mean, I feel like I can communicate much more better with writing than it is with verbal communication. But that's one thing. Another thing would also be drawing pictures and being an illustrator. There's a lot of people that like to express what they're feeling just by being an artist, and that's why I'm always so passionate about artists too. And even dedicating a whole chapter in art in the Becoming One book, because it really is important. That's just my way of saying, hey, you got something to share. So why don't you just draw on the pages and that kind of thing, and just show your talent, all that kind of thing. And you never know. You just never know. What your form of communication would be, whether it be illustrations or even video production and writing. Because who knows? You might sell over 100,000 copies here and there too. And one thing I've also was informed over there on my team is that also just do sign language as well too. That's also another way of form of communication, and it just kind of looks cool too. Even my uncle is really good at sign language too, and once you start trying that, you can communicate pretty well. So there's so many ways of doing it. So the challenge is that I give to a lot of people is simply try to imagine and use your imagination of what can you do to express without the use of verbal communication. And you can even come up with a list. So it's all in the work of imagination right there. It can be fun.
Alrighty. So just because there is a lack of verbal communication does not mean that our clients do not understand us. So we should be looking out for other clues and forms of communication from our clients. So we should be treating our clients who are nonverbal just like we would a client who communicates verbally. We should be looking for those other cues of communication that our individuals utilize. And now we will get into what actually is nonverbal communication. So there are 10 types of nonverbal communication, and nonverbal communication can make up to 70% of communication. If a client is nonverbal, we still need to be using active listening, making sure we are paying attention to our client's nonverbal cues. So there are 10 universal types of nonverbal communication. This includes paralanguage, which is the tone and pitch of voice. There's going to be body language, which includes posture, kinesics or gestures. So this is an important aspect of body language. There's facial expressions, which is universal communication. Proxemics, otherwise known as interpersonal spacing. This can portray our relationship with someone, so personal versus professional spacing. There's gaze or eye contact. This can show our interest, our care. There's haptics, otherwise known as touch. So, touch as a method of communication. 8, appearance, so personal presentation. This could be smell, clothing, being unkempt. And chronemic, so the study of how time impacts our communication. Fast or slow to respond sends different messages. And then there's those physiological responses. So nonverbal signals of how our body is responding and is out of our control. So these could be those things like blushing, sweating, tearing up. Those are physiological responses. So first we'll go over paralanguage. So this is also known as vocalics. It is the non-lexical, otherwise not pertaining to words, component of communication by speech. So for example, this is going to be intonation, pitch, and speed of speaking, hesitation, noises, gestures, and facial expressions. So for here, we're going to be focusing on the tone and pitch of sounds. So for that tone, strong sounds can indicate confidence, happiness, or enthusiasm, whereas soft or hesitant tones can indicate disapproval or hesitation. If someone has a high pitch to their sounds, it may indicate excitement or uncertainty, whereas a low pitch could indicate boredom or authority. In this context, paralanguage can include the tone of moans, yells, and sounds coming from clients. It does not have to be applied only to the spoken word. And body language is the use of physical behavior, expressions, and mannerisms to communicate non-verbally, often done instinctively. So body language can also provide insight into a person's emotional condition. So for example, you likely already know that someone who crosses their arms is guarded or discontent, even when they claim the contrary. Reading body language is like learning a second language and can help separate perception from reality. So first, looking at posture, we turn to items or people we are interested in and turn away from what we dislike. Our posture can indicate many emotions, including some aggression or defensiveness, interest and relaxation, and more. And then gestures. Gestures can give an emphasis to what we are feeling. These are deliberate movements and signals and are an important way to communicate without words. And some gestures are universal, but others do have cultural significance. Make sure to take into account your client and what culture and ethnicity that they are, so that way you are not doing any gestures that could be offensive in any way. And then our eye contact and gaze. So psychologists have found that people's emotional changes are mainly transmitted through those facial expressions. So with our eye contact, this can show interest in the activity or session. We look at something more frequently, the more we are interested in it. And it is an important part of active listening. And then blinking. So there is a blink to speak eye sign language. So blink to speak is an eye sign language that was developed for paralyzed clients that cannot communicate further. Blink to speak is a set of 50 commands which can be used by anyone to speak with their eyes. So that is very interesting and very cool. If you would like more information on Blink to Speak, do not hesitate to reach out. But in Blink to Speak, there is also sets that you can do to come up with your own Blink to Speak commands as well. And we do just need to be mindful of those cultural expectations when it comes to eye contact and gaze. So, for example, in many Eastern and some Caribbean cultures, meeting another's eyes can be perceived as rude or aggressive. Make sure to refer to your client and understand their preferences. But why are we going through facial expressions? Why are we learning about this? So first, we need to increase our own skills in this area before teaching clients. So we as professionals need to develop our skills to recognize emotions in others. We need to be aware of what our own facial expressions are communicating to decrease any misunderstandings. And it may be necessary for us to teach facial expression recognition to our clients if they struggle with expressing or interpreting emotion. The next few slides are for your own information and may inspire you to teach the skill to your clients. So first, we are going to be going through anger. So this is the first of the universal emotions that are portrayed in facial expressions. So when someone is expressing anger, this is often characterized by the eyebrows being drawn down and together. The eyes are opened wide, staring hard. The mouth is rectangular, or the lips are pressed tightly together. So here we have a visual representation of true anger being portrayed. So there's a clear anger display with the eyebrows down and together, and this is the open rectangular mouth variety. This often indicates a less controlled anger. Next is happiness. So the next up in our 6 universal emotions is happiness, which is often characterized by the eyes narrowed, wrinkling around the eyes. The cheeks are often raised and lips are pulled back and the teeth are exposed in a smile. So we have our first one here. However, this is portraying a fake happiness or an ingenuine smile. So notice that there's only really a flat action to it. So it's not out and up at the outside corners, and there's a lack of eye activation. But if we look at this next one here, it is a stark contrast. So there's a much more animated smile. So the corners of the mouth are going up and into the face, and there is that obvious eye muscle activation. Our next facial expression is characterized by sadness. So this includes inner corners of the eyebrows being pulled up and together instead of down where our anger is. So they're being pulled up and together. The upper eyelids are drooped and the eyes are looking down. The lip corners are also pulled downwards. So here we have our first picture. And this is a fake sadness expression. So this is a manufactured expression commonly referred to as a pout or a manipulation of the chin to elicit a desired response. So just notice that there is an absence of eyebrow activity and there's an abnormal retraction of the chin. Here we have instead a subtle true sadness display. So notice that the eyebrows are together and up slightly with the telltale vertical wrinkle in the center of the forehead there. The cheeks subtly slumped and outside corners of the mouth pulled down slightly, and there's a subtle retraction of the chin instead. Next up is going to be our surprise. This is often characterized by the eyebrows being raised and not drawn together in any way. The upper eyelids are raised, but the lower eyelids are neutral, and there is a slack jaw that is dropped down. Here's our first one, and this is a more suppressed variety of surprise. We can see those eyebrows are up and the eyes are wide, but the lips are stretched and tightened. And here we have our exaggerated surprise. So we can see clearly the eyebrows are up, eyes are wide, and that mouth is making that O kind of shape. Next, we have fear in our universal expressions. This is often characterized by the eyebrows are raised and drawn together. The upper eyelids are raised and the lower eyelids are tense. The jaw is dropped, but oftentimes the lips are stretched horizontally backwards. And here we have a picture of true fear. So the eyebrows are up and together and the mouth is stretched back. And lastly, we have our last 6th facial expression, which is disgust. This is often characterized by lowered eyebrows. There's a wrinkling of the sides and bridge of the nose. The lips can be slightly raised, protruding, and it often looks like an inverted U. Here we have a picture of true disgust. We can see that the nose is crinkling, the upper lip is raising, as well as this one here, showing the eyebrows and a true form of disgust. And next up, we'll start to get into the rest of our body language types or nonverbal communication types. So we have personal presentation. So personal presentation is a communication skill that involves how individuals portray themselves in daily situations. Understanding our clients' baseline personal presentation can help us determine their state of mind. And then the time is also known as chronemics. So first is that time. So the amount of time it takes for someone to communicate can indicate true feelings. If someone is slow to respond, it could indicate uncertainty. Though if someone is communicating nonverbally, the time they take to respond may be slower anyway. Make sure to have patience with your clients. And then there's that smell. So someone's smell and hygiene could indicate where they are in their mental health journey. If someone who normally has good hygiene is malodorous, they could be experiencing high depression symptoms. And then those other nonverbal clues. So firstly, interpersonal space. This is putting a specific distance between yourself and another person in order to communicate a message and to feel comfortable. There are certain distances from one person to another which are considered to be acceptable, dependent upon the situation. This is known as proxemic. So it's the bubble that we have around us. And we should not be getting into our client's bubble. If you do need to get close to a client for ADLs or hygiene, always ask for consent first. And this can portray different information based on the space between us and our clients. We always want to make sure that we are being professional and keeping a professional distance away from them. And then there is our haptics or touch. So haptics and touch is used in many ways in our daily lives, such as greeting, comfort, affection, task accomplishment, and control. So this can communicate both information and emotions. Just be careful, touch can be triggering, so care needs to be taken with touch and haptic communication. And again, very important, if you do have to touch and get close to clients for activities of daily living or those ADL, always ask consent and make the client aware that you are there for assistance. And then lastly, there are those communication boards. So these can be physical, digital, words, pictures, a communication method to understand our non-speaking client. So this is a very important part of a lot of nonverbal communication. So someone may have had the ability to point to letters, numbers, words, or pictures to communicate. Figure out what works best for those different clients. Here is an example of a communication board. So a communication board that can be used with our clients so they can make sentences or let you know how they are feeling. Clients who are able can point to what they're wanting to say, or the pictorials along with the words can help those with difficulty reading or understanding language. Clients would often point to multiple of the blocks here. So it could be I am sad, I am happy, I feel sad, I feel at peace, whatever it might be for that client. Here we have a more straightforward board, so a client can just point to one of the choices instead of multiple. This can be helpful for our clients in a facility, especially who have trouble communicating with their facility staff members, such as aides, nurses, or other workers. So they can say things if they are in pain, if they need oxygen, want to be adjusted, or need that hygienic care. And next, we have some tips to bring into your session with your nonverbal clients. So first, observing those nonverbal cues. So these nonverbal cues can give more insight into our client's mental health and be on the lookout for nonverbal signs of mental health symptoms. And then close-ended questions. So close-ended questions allow your client to perform a simple movement for yes or no and allows clinician to be more certain of their services. Next is sign language. So understanding basic signs can assist you and your client in communicating and can empower nonverbal clients to achieve their needs. It could be helpful to have paper. So some clients may be able to write what they want to communicate, and others enjoy drawing or having pictures. Having paper and writing utensil handy can go a long way. and having practice and patience. So nonverbal clients deserve the same care and time as verbal clients. Be patient and practice and make sure to still individualize treatment to fit the needs of our clients. Here is a video from a non-speaking person on tips for communicating with nonverbal communicators.
Hello everyone, my name is Jill Clark. I have a disability called cerebral palsy which affects my muscles and my speech, so as you can see I am in a wheelchair and communicate using a communication device. I use a tracker done on my head to control the program on my device. I like to talk a lot, so my communication device is one of the most important thing in my life. Communication is the key to everything, and everyone has the right to have a conversation no matter what. So, let me tell you my top tips based on my own experiences. Tip 1: be patient. As I reply to you through a communication device, I need some more time to get my sentence together. Shops. With my mom. If you are patient, it shows me that you are interested in talking to me, and I will feel more comfortable having a conversation with you. Tip 2: keep eye contact with me, not with my carer. Due to my disability, I always have people with me, and often people look at them whilst they are talking and not at me. It makes me feel as if I am not there, so please be mindful of that. Tip 3: speak to me in the same tone of voice you would use with any other adult. My pet hate is when someone speaks to me as if I am a baby. There is no need for that. I am an adult who understands what you are saying, so speak to me as normal. Well, these are my top tips. I hope that you learn something from them and be able to have a good conversation with me. Even although I talk through a communication device, I can still talk as much as everyone else. So let's start talking.
Awesome. So next we will get into adapting some services. So we need to be sure we are adapting our services to fit the needs and abilities of our clients so that they are receiving the best individualized care possible. So we may be corrected when interpreting our clients' nonverbal cues, and that is okay. So we may need to interpret behavior for a nonverbal client by identifying and labeling the emotions that are tied to what they are communicating. And again, it is okay if you're corrected. The point is that you're trying to listen to what they are saying and communicating to you. And other activities that can facilitate the labeling of feelings and emotions include the use of pictorial representation of faces to facilitate the identification of emotions. It could be the use of journaling or writing if they have that capacity, or the use of picture journaling as a substitute for writing, drawing pictures or even putting pictures into a journal. And then there's also expressions through music. And for ViaQuest staff here, we can still utilize the 10 TBS interventions with nonverbal clients. Nonverbal clients can benefit from and deserve the same direct care and support a verbal client would receive. So how can nonverbal clients benefit from TBS services? Just like everyone else. So by providing interventions, we can help with symptom management, education or advocacy, and increase quality of life. When we're getting into our billing and documentation tips, so first our care plans, we always want to focus on our client's SNAP. So what are their individual strengths, their needs, what abilities do they have, and what are their preferences? So their SNAP, strengths, needs, abilities, and preferences for treatment. And then understanding these can help our clients communicate easier. We never want to try to implement a communication method our clients cannot participate in. If they have an inability to read and write, though we try to get the client to write down their feelings, we're not helping them progress in treatment. A pictorial communication board would then be best. And then what their goals are. So is language something that they want to work on? What is their diagnosis and what are their barriers? And then our progress notes. So you want to make sure to be person-centered. Your intervention should fit your client's abilities and make sure to have strong coordination with other staff members. And then our communication. So you want to bring in all the ways your client communicates. So if your client is not verbally saying anything, you shouldn't say that they're verbally saying something, or you shouldn't say that they stated. You can say that they indicated something through a communication device. You could say that you're picking up on things through nonverbal body language. And then complete a mental status exam to observe your client's current physical or mental health. Some of our best practices. It is important to clarify and confirm the accuracy of our clients' responses. And we should be focused more on the concrete words or meanings being generated than on the manner of communicating. And adapting our notes. Specifically show how the client indicated or selected their communication to limit misunderstandings about precise communication with the client. Always important to explain what you, the staff, did and how the client reacted. If they did not like the intervention, how do you know? So if a client can only offer yes, no responses, it is important to clarify and confirm the accuracy of those responses. When working with a nonverbal client, it is ironically the nonverbal communication that is lessened, as the client and I are focused more on the concrete words or meanings being generated than on the manner of communicating. So if our clients cannot literally tell us how they feel about the session or meeting with the staff, then how do you know that they enjoyed or did not like it? Look at those facial or body language, and what did they indicate with their communication device? Here we have our intervention example. So the 10 interventions of TBS can be applied to all clients, including nonverbal clients. The most important thing to remember is making sure that the activities of the interventions are personalized. So this is an example of how to complete an MSE or a mental status exam with a nonverbal client. So we can see here in this example, our client had an anxious mood and restless behavior. And in that providing detail section, Ben appeared to be experiencing more anxiety within the session, as evidenced by his increased restlessness of his movement, his rapid eye movement, and breathing rapidly. And any reported changes in those medical symptoms. Ben utilized his communication board to report that he was experiencing issues with his physical health, including needing to use oxygen more often. So we can see that this client Ben test, we can see he's anxious due to his body language, facial expressions, and breathing, and we can infer his mood through our clinical observation. We can also see how Ben communicates through his communication device in the medical symptoms box instead of documenting that he voiced or stated. And next we will get into the example intervention. So the intervention of skill building. So here's an example session with Ben test and how to write a note about a nonverbal client. The intervention we are implementing with Ben here is going to be skill building. And we can see the activities include practicing relaxation skills and utilizing coping skills to decrease those mental health symptoms, with the specific coping skill being followed, a guided meditation video. So Ben was able to participate in the session adequately, and he demonstrated the skill with TBS. So then in that session note in the client response. So Ben appeared to be experiencing anxiety as evidenced by his heavy breathing, eyes darting around the room, and blinking rapidly. Ben utilized his communication board to report he was experiencing issues with his physical health, including needing to use oxygen more often. Ben, utilizing his communication and feelings board, reported that he was feeling bad and fearful. Ben shook his head yes and cooperated in utilizing guided meditation as a coping skill was suggested to Ben. Ben initially continued presenting as anxious, as evidenced by his breathing continuing to be rapid and having more body movement than normal. Ben demonstrated his ability to follow the guided meditation and his breathing began to slow. At the end of the guided meditation, Ben indicated through his feeling chart that he was feeling better and utilized his communication board to thank QMHS for their time. Ben shook his head no when asked if he would like to do anything else within his session. So we can clearly see a beginning, middle, and end here with Ben as we bring in our observations from the MSE. We document what accurately happened in the session, such as the utilization of a communication board, instead of Ben verbalizing anything. And Ben also benefited from the TBS skill building session as it was observed his breathing slowed and he was less restless, indicating less anxiety symptoms. So we always want to make sure to have a continued adaptation. So social communications are an essential human need. Even when the individual is a nonverbal communicator, it does not prevent meaningful and empathetic communication. A reduced ability to communicate or the loss of speech can be profound, and when comorbidity is present, it can make communication more difficult between staff and a client. There can still be a dialogue, even when it is not a typical verbal conversation. A client can still be helped to find and use their personal voice, even if it is not a spoken one. So some of my clients use nonverbal methods of communicating, such as gestures, a letterboard, or an electronic device for spelling or voicing their typed comments. You may need to extend that patience and concentration when working with a nonverbal client. If a client can only offer those yes or no responses, again, it is important to clarify and confirm the accuracy of those responses. And some pointers to keep in mind, some of those best practices: always obtain records in advance if possible when working directly with your client. Become familiar with collateral informants and supports for the individual to assist in the development of your professional relationship. Understand that any communication or direct care can be stressful for all involved. Working with a nonverbal client in any capacity will likely take more time, so having patience is key. And reminder to use language that correlates with the expressive and receptive language skills of the client. So that is all I have for you. If there are any questions, please feel free to reach out. But otherwise, have a good day.